For the longest time, the playbook for treating peripheral arterial disease, or PAD, well, it was pretty simple. But that's all changed. Landmark trials have come along and just completely ripped up those old rules. So today we're going to dive into the evidence, the stuff that's totally transforming how we use antithrombotic therapy, not just to save lives, but to save limbs too. First things first, let's just get a sense of the scale here. PAD isn't some rare niche condition. We're talking about over 200 million people around the world. I mean, just think about that. That is a staggering number of people walking around with arteries that are slowly shutting down, putting them at just, incredible risk. And here's the thing, the risk. It's not just coming from one direction. PAD is this devastating double whammy. On one hand, you've got MACE. That's major adverse cardiovascular events. Think heart attacks and strokes. But on the other hand, you've got MALE, major adverse limb events. We're talking acute limb ischemia, major amputations. So we're going to fight to save both life and limb. So here's our game plan. First, we'll really get to know this dual threat and the tools we have to fight it. Then we'll dig into the game-changing evidence for both chronic PAD and that super high-risk time after a procedure. And finally, we'll wrap it all up into a practical plan you can actually use.
All right, let's get into it. To really get why our treatments work, you gotta understand the enemy. And in PAD, clotting or thrombosis, it's not just one simple thing. It's really more like a war being fought on two different fronts. So on that first front, you've got what's called platelet-driven atherothrombosis. Think of platelets as the first responders, rushing to the scene. A plaque ruptures and boom, these sticky little guys pile up to form a quick plug. But then on the second front, the coagulation cascade kicks in. This is like the heavy construction crew. They use a substance called thrombin to build this tough fibrin mesh, turning that temporary plug into a solid artery-blocking clot. The key is, both of these pathways are fired up, and they're both driving the danger. Okay, so if we're fighting villains on two fronts, we're gonna need a team of heroes, right? And that's exactly what our antithrombotic arsenal is. It's a collection of different strategies, each designed to go after one or even both of those clotting pathways. Basically, we've got three main plays in our book. The first is single antiplatelet therapy. You'll hear it called SAPT. That's just one drug to make platelets less sticky. Then there's dual antiplatelet therapy, or DAPT. You guessed it, that's two drugs to hit those platelets even harder. And then there's the big one, the new approach, dual pathway inhibition, or DPI. This is the one that really changes the game. It uses an antiplatelet plus a low-dose anticoagulant. It's designed to fight on both fronts at the same time.
Okay, now for the really interesting stuff. Let's get into the clinical evidence for managing patients with chronic stable PAD, because this is where things have just been completely turned on their head in the last few years. We've seen a huge shift away from what used to be the absolute standard of care. For what felt like forever, the go-to move was just single antiplatelet therapy. So the question on every clinician's mind was pretty simple. If I'm only going to use one drug, which one's better, aspirin or clopidogrel? Well, it turns out the evidence on this is crystal clear. That answer came from the landmark Capri-A trial way back in '96, and what they found was pretty amazing. When they put clopidogrel head-to-head with aspirin, the group that really stood out were the patients with PAD. They saw a nearly 24% relative risk reduction in ischemic events. And just like that, clopidogrel became the preferred single agent for anyone with symptomatic PAD. So, of course, that gets you thinking, okay, if one is good, are two even better? It's the logical next question, right? Well, the Charisma trial looked at exactly that. And the answer? A big, clear no. Turns out, adding a second antiplatelet for these stable PAD patients didn't really move the needle on preventing events, but it did jack up the bleeding risk. So, for your everyday chronic management, DAPT is not the way to go. And then, everything changed. The COMPASS trial dropped, and it was a true game changer. This was the study that forced everyone to stop thinking just about platelets and start thinking about hitting both of those clotting pathways at the same time. And wow, the results were just remarkable. You take the dual pathway approach, that's a low-dose anticoagulant plus aspirin, and compare it to just aspirin. What happens? It slashed major cardiovascular events by 24%. But here's the kicker, especially for PAD patients, it cut major adverse limb events by a staggering 46%. That is a massive, massive win for saving limbs. But, and this is a really big but, it's crucial to know that this more aggressive therapy isn't for everybody. If you have a patient who is asymptomatic, meaning, yeah, they have PAD, but they don't have any symptoms like claudication, the evidence is really clear. Trials like POPAD show that antithrombotic therapy gives them no benefit. So in that case, it's actually not recommended.
Okay, so let's shift gears now to an even higher stakes situation. I'm talking about that critical period right after a patient has had a procedure, like a stent or a bypass, to get blood flowing back into their leg.
This is where the Voyager PAD trial comes in and gives us the data we need. They took over 6,500 patients right after their procedure, and they tested that same dual pathway strategy from the COMPASS trial against plain old Aspril.
And again, the results were just so powerful. The combination therapy cut the risk of both limb and cardiovascular events by 15%. But here's how you know it's a big deal. The number needed to treat the NNT was just 29. Now think about that. That means you only have to treat 29 people with this strategy for 3 years to stop one of these awful events from happening. That's incredibly effective. Okay, so we've got all this incredible practice-changing data from Capri, from Compass, from Voyager Ped. The big question is, how do we boil all this down into a simple, actionable plan that we can actually use in the real world? Well, it actually boils down to 3 really clear scenarios. Number 1, if your patient is asymptomatic, the evidence is simple: no antithrombotic therapy. Number 2, if they have chronic symptomatic PAD, the COMPASS trial tells us dual pathway inhibition is the preferred way to go. And number 3, if your patient is fresh out of a revascularization procedure, Voyager PAD says you start dual pathway inhibition right away. All right, let's make this real. Imagine a 68-year-old comes into your clinic. They have claudication, but they don't have a high risk of bleeding. So based on everything we've just talked about, what's the best therapy for them?
The answer, based squarely on the evidence, is dual pathway inhibition. Why? Because it's the only strategy that has been proven to powerfully reduce both of those threats we talked about, the cardiovascular events and, so importantly, those major limb events. So let's just quickly recap the big take-home messages here. Asymptomatic PAD, no antithrombotics. Symptomatic PAD, but you have to use a single agent? Capri tells us clopidogrel beats aspirin. But for most of these patients, COMPASS has set a new standard. Dual pathway inhibition is king because it slashes both MACE and MALE. Right after a procedure, Voyager PAD says it's DPI again, with that incredible NNT of 29. And don't forget, DAPT, or dual antiplatelets, has no routine role here. This is a fundamental shift in thinking, focusing on that dual pathway for our sickest patients.
You know, when you step back, the progress is just incredible. We've moved from thinking about a single pathway to this dual pathway approach that truly protects both life and limb. It really makes you wonder. As we get even better at targeting platelets and thrombin, what's the next big frontier going to be in this fight against PAD? Thanks so much for tuning in.